have to take a demographic data of the patients because it is very important. The chief complaint, history of presenting illness, past medical history, surgical, family history, occupational history, drug history, social history, and personal. This you have to do it whenever you are taking any history. Name and address of the patient is very important, from which part of the city he is belonging to. Age, because there are certain diseases which may be common in different age groups. Address should be in detail. Usually we write it in Landi area. Suppose tomorrow if we have to trace out which part of Landi has got more patients coming with asthma. So you will know exactly which is the area. Like today, these days we are running, because of the COVID, we have to actually trace out the patients or their contacts. So it is very important that the address should be in detail. Similarly, age of the patient, gender, and address. Again, as I mentioned to you, address is very important. Occupation, as far as chest is concerned, occupation is very important. There are a lot of occupational lung diseases. So you should know what is the occupation. Occupation, usually we write, once I was analyzing my data in my ward, we used to keep a record, and after a couple of years, I came to know that majority of the occupation was written as laborer. Now, laborer doesn't mean anything. I then instructed to my trainees that you have to write, even if you cannot write it in English, you have to write it in Urdu, the exact occupation. And if it is, for how long he has been working into that, and what was his previous occupation. So it is very important and detail occupational history, because in chest, a lot of diseases, all the pollution goes into the lungs. So a lot of diseases are related to occupation. Date of admission is very important. Not only, the date of evaluation whenever you are examining these patients. Whenever you make an entry, remember that, this is usually a lesson for you for rest of your life, that you have to write the date as well as the time when you are recording these things. Because these days, medical legal issues can arise at any time. So exact date and the time when you have seen the patient. You may have seen the patient 10 hours ago, and they will say that a patient suddenly collapsed. So the exact time of examination and exact time of entry of your data should be recorded. Now, coming to the complaints regarding chest, there are only 5 complaints. That is cough with or without a sputum production, breathlessness, chest pain, hemoptysis, and wheezing. Hemoptysis and wheezing can be a sign as well as a symptom, but these are the 5 main symptoms. So the whole chest medicine revolves around these 5 symptoms. Rest are not specifically related to chest. You always take that's why it is very difficult to make a diagnosis just on the basis of history, unless you have taken a detailed history of each and every symptom which the patient is experiencing. So you should mention, and the duration of important is also important. So history start with history of presenting illness, explain in detail about each and every symptom for the current episode. And if it is related to the previous histories, then you can say this patient has come with a cough for the last 2 weeks, but he has been having recurrent cough for the last 6 years. So this is how you have to correlate that this is a part and parcel of the same disease, which is going on for the last 6 years. Investigation done, admission to the hospital, previous any hospital admissions or not, that should be recorded. Right, so we were discussing about the symptoms related to chest diseases. Cough is the major symptom. Most of the patients who attend OPDs, they will be complaining of cough. Cough is a reflex act of forceful expiration against a closed glottis. And this is because of large positive intrathoracic pressure. The main aim of the cough, it's a reflex mechanism. Main aim is to keep the airway clean. Nature doesn't allow anything to go into airways. And cough is basically induced to remove anything which either go from the top or which generates in the lungs that should be expelled out of the airways. So it's a protective mechanism, and one should not try to stop the cough. I think you should be trying to address the cause of the cough rather than giving antitussive or cough syrups to prevent the cough. Like you don't stop the diarrhea. And similarly, you should not be stopping the cough unless you have been treating the main cause of the cough. Now, as you know, that cough can be generated from number of receptors which are present in nose, sinuses, posterior pharynx, pericardium, diaphragm, ear canal, esophagus, stomach, and pleura. So it is very difficult to pinpoint that from where the cough is being initiated. The reflex, the stimulus has been taken either by all these nerves, trigeminal, ossipharyngeal, phrenic, and vagus, and they have been taken to the medullary center where there is a cough center. And as you know that the medullary centers are not in the voluntary control, so cough is an involuntary act which you cannot suppress totally. So from there, I mean, the nerves goes to the spinal motor for the expiratory muscle, phrenic nerve take it to the diaphragm, and the vagus for the larynx, trachea, and bronchi. Because all these organs take part in the cough. So how do we differentiate various type of cough? Depending upon the duration of the cough. Usually when it is less than 3 weeks, it is called acute cough, and we do not like to investigate so much about it and resources. Mostly it is viral induced upper respiratory tract infections. It clears up with the time. Similarly, lower respiratory tract infections. Whooping cough is also a cause of that which clears up on its own. And similarly, inhaled irritants like dust, smoke, and chemicals. I mean, exposure to these is very, responsible for causing acute cough. And then we have a subacute, which lasts for more than 3 weeks and less than 8 weeks. Again, it can be viral, post-infective. After the infection is over, the cough may last for a longer period of time, post-nasal drip and gastroesophageal reflux disease. When it is more than 8 weeks, it is called chronic cough, and it can be a lot of causes. I mean, tuberculosis, asthma, COPD, bronchogenic carcinoma, eosinophilic bronchitis, post-nasal drip, GERD, use of drugs like ACE inhibitors, and congestive cardiac failure. Then there is another type of cough which usually or mainly occur during the night. And when it cough increases during the night or mainly occur at night, then one should expect regurgitation, esophageal, gastroesophageal regurgitation. It can be due to chronic bronchitis and asthma, because you know that early morning before you wake up, the bronchial tone increases, and there is the most chances that people will have cough and shortness of breath. Obstructive sleep apnea, which usually occurs when patient tries to go to sleep. Similarly, left ventricular failure and aspiration also occur while you are sleeping or during the lying position. So these are some of the very important that you should be knowing the time of the onset of cough, when it starts, and where it is predominantly there. The other way of differentiating, besides that it is acute, chronic, or subacute, or whether it's nocturnal or not, is whether you do a chest X-ray and see if the chest X-ray is normal or not. With a normal chest X-ray, 80% of the cough is related to the first three causes, that is asthma, postnasal drip, and esophageal reflux, gastroesophageal reflux. So 90% or 80% of the causes are these three. So whenever you have got a cough, get a chest X-ray. If it is abnormal, then your line of thinking or investigation goes to the abnormality which is visible on the chest X-ray. But if it is normal, then you should look for asthma, postnasal drip, and GERD. But there are other causes like chronic bronchitis, acute left ventricular failure. In the early stages, you may not have a normal chest X-ray. Sometimes foreign body aspiration, particularly in children. Some of these foreign bodies are not radiopaque, so they will not be visible on a chest X-ray. Intrabronchial tumor, when the tumor is in the bronchi, it will not be visible on the chest X-ray. Upper respiratory tract infection like sinusitis, chronic ear infection, and so on and so forth. Pharyngitis also. And then there are drugs. You should always remember, particularly ACE inhibitors are notorious for causing cough. So 10% of the patients who take ACE inhibitor will have a chronic cough. Now, beside that, you have to ask whether the cough is dry or a productive. When it is more than 1 tablespoonful of sputum, it is called productive, or more than 5 ml per day. So if it is productive, you have to ask about the sputum, the consistency, the amount, the color, the postural variation, and the smell. For instance, consistency, serious type of like saliva is usually seen in upper respiratory tract infections, and another one, bronchoalveolar carcinoma. It's called now mucinous adenocarcinoma, no longer called bronchoalveolar carcinoma. But again, this can produce a large amount of very large amount of various copious amount of white sputum, like a sputum, like your own sputum, sorry, like your own saliva. Similarly, it can be mucoid in chronic bronchitis and bronchial asthma, and mucopurulent in bacterial infections. Now, the quantity is almost very important. If it is more than a cupful in 24 hours, it is called copious amount, and you should think about bronchiectasis, lung abscess, necrotizing pneumonia, alveolar carcinoma, or now called mucinous adenocarcinoma, rupture of the empyema into the bronchus. Sometimes the empyema can rupture into the bronchus. And bronchoria, again, it is seen in mucinous adenocarcinoma, large quantity of clear saliva-like sputum produced in a large amount. Color of the sputum, yellowish green, bacterial infection, black, cold water, pneumoconiosis, sometimes fungal infection like aspergillosis can produce black color infusion. Pink and frothy pulmonary edema, rusty sputum with a little bit of darkish blood, which is pneumococcal pneumonia, red color jelly-like sputum, Klebsiella, and blood trench sputum again, or frank hemoptysis can be in tuberculosis. Postural drainage, these are the two postural variations. These are the two conditions in which a sputum is induced by changing the position of the person. Like for instance, if he's lying, he take a turn on the left side or the right side, suddenly start bringing up a lot of the sputum, then you should be thinking about these. Foul smelling, lung abscess, bronchiectasis, anaerobic bacterial infection. Here, there will be very foul smelling. So all this detailed information should be taken about the cough. Now coming to the dyspnea. Dyspnea is basically a subjective term experiencing discomfort in breathing. Normally when you breathe, you are not aware that you are breathing, but when it's become uncomfortable, it is called dyspnea. It can be interaction of multiple physiological, psychological, social, and environmental factors may induce psychological or behavior response. So dyspnea is sometimes even psychogenic also. So there is a physiological causes of dyspnea like mountaineers, exercise, hypercapnia, and anemia. These are considered as physiological cause. Then can be respiratory causes like COPD, asthma, chronic airway infections, bronchogenic carcinoma, cardiac like MI or left ventricular failure, metabolic like diabetes, hypokalemia, neurological, whenever the respiratory muscles are not functioning like Guillain-Barré or myasthenia gravis. I mean, we always suspect that breathlessness can be caused by either lung disease or the heart disease. If they are clear, we start blaming it as a psychogenic. But remember that muscle strength has to be also checked, because you can have metabolic cause, or you can have neurological causes, and they may not be apparent. Quite often they are being termed as neuritics. Similarly, metabolic causes, if you don't do the blood test, if the person is in renal failure, I mean, the raised urea will cause a lot of dyspnea. Similarly, diabetic ketoacidosis will cause dyspnea. So these should also be checked. Onset, duration, severity, aggravating and relieving factor, postural variation, and diurnal variation. These are the common questions which you should be asking whenever you come across a patient with dyspnea. So let's take them one by one. The onset, that is very important. If it occurs within minutes, when you write sudden onset of shortness of breath, then sudden means that it is sudden. So then the causes are pneumothorax, pulmonary embolism, inhalation of a foreign body, laryngeal edema, left ventricular failure. Then the cause should be one of these 4, 5 or 6 causes. There can't be anything else when you write sudden. When it takes hours to develop, then it could be acute respiratory distress syndrome, bronchial asthma, pneumonia, left ventricular failure. When it develops slowly over weeks or months, then COPD, ILD, pleural effusion, thyrotoxicosis, left ventricular failure. Another important is the relationship with the posture. And dyspnea, which aggravates on lying down, should always be considered as heart failure or COPD or asthma. So patient is more breathless when he or she tries to lie down at night, but when he sits up, then he is less breathless. Paroxysmal nocturnal dyspnea. This is very typical of left ventricular failure. Basically, the difference between orthopnea and PND or paroxysmal nocturnal dyspnea is that in paroxysmal nocturnal, patient wakes up from the sound city with breathlessness, sound sleep with breathlessness. So waking up from the sleep is an important point, because when you sleep, there is a certain mechanism which happens in the patient with heart failure, and patient suddenly wakes up with dyspnea. This is called paroxysmal nocturnal dyspnea. Then there is a pletapnea, where patient is all right in lying position, but become more breathless in sitting position. So the causes are patent foramen oval, ASD, atriovenous malformation in the lung, and hepatopulmonary syndrome because of the shunting of the blood. And when you are in a sitting position, there is more likely that shunting will increase, and so patient become more dyspneic in the sitting position. Then there is another one called treponia. That is the dyspnea on lateral decubitus position. Suppose if you have a massive effusion on the left side, and if you lie on the right side, because your right side is normally functioning now or taking a breathing. So if you lie on it, there is a splinting of that side also. The left, for instance, if there is a large effusion on your left-hand side. So if you lie on the right-hand side, the right-hand side was basically the lung was moving and breathing. But when you lie on that side, it gets splinted. So you will get more short of breath on lying into that position. But if you turn back or lie on the disease side, you will not feel breathlessness that much. So this is treponia. There are other ways of describing the grading of the dyspnea. There are a lot of, the best thing I would suggest, instead of remembering these grading, you should write what causes the breathlessness. That is a breathlessness at rest, breathlessness on mild exertion, breathlessness or strenuous exertion, or doing daily activities. So if you write that, it clearly gives you an idea how bad is the breathlessness. But again, grading is done by MRC scale, which is called Medical Research Council of British. They describe grade 0 as breathlessness only when you do excessive exercise, one, get short of breath, on hurrying on the level ground or walking up the hill, when you bring it very fast, or you go up the climb. Level 2, on the level, you are walking on the level at a slow pace, and you are more breathless as compared to the age of the person. Unlike, for instance, if somebody of your age, height, and build walking with you, he is not short of breath, but you are short of breath. So this is level 2. Stop after walking for level 3 is just a few hundred yards, and you become short of breath, or you become breathless even in doing your daily activity at home. So these are different type of grading. Then there is another New York Health Association scaling. Again, they are dependent on these things. These are the symptoms on which this dyspnea occurs. So you have to give the description in detail. That's much better. And again, this this is American Thoracic Society grading on breathlessness. So it's much better that you write what causes the breathlessness. Then aggravating factors. Exposure to allergen typically suggests asthma. Exercise. Again, exercise in asthma, you usually feel short of breath when you stop doing the exercise. But COPD patient will, or heart failure will feel short of breath when they are doing the exercise. Similarly, certain drugs, like if you give beta blockers to a patient with heart failure or asthma, they will. Cold weather. Again, exposure to cold weather giving shortness of breath is typical of asthma. Relieving factors, medication. For instance, if you are relieved by giving injection furosemide, then it is heart failure. But if it is relieved by taking Ventolin inhaler, it is COPD or asthma. Rest, I mean, most of the breathlessness usually relieved by stress, by rest. But in cases of heart failure, when you do an exertion, you get short of breath. If you rest, immediately you recover. But in COPD, it may take a little while before you recover. So these are subtle differences as far as leaving factor. Diurnal variation, again, asthma has got significant diurnal variation. It is more severe in early morning as compared to evening. Lung abscess and bronchiectasis, I have already mentioned that the sputum is induced by change in the posture. Similarly, the dyspnea also becomes worse. Finally, the chest pain. The chest pain, again, the site, onset, duration, severity, character, radiation, associated symptom, aggravating, relieving factor, diurnal variation, and retrosternal pain. Remember that the most two important causes is cardiac as well as respiratory causes. Cardiac causes, the pain is usually tightness or somebody sitting on your chest, constricting your chest. When the person put both his arm on the chest and say, I have got a pain in the chest, this is very typical of heart pain. But when he points with a finger that I have got a pain here, that remember that this is most likely not a cardiac chest pain, it could be a musculoskeletal chest pain. So remember that we have to make sure that it is cardiac pain. Secondly, duration of cardiac pain is very important. It can't last more than 20-30 minutes, because if it lasts for more than that, it is cardiac, then you will develop an MI. So there will be ECG changes. I see a lot of patients who come, or I get the history narrated to me that this patient had chest pain for 24 hours. I said, how is the ECG? ECG is normal. So I am at peace that this could not be a cardiac pain, because if somebody has got pain for such a duration and it is cardiac, you will find some ECG changes. Similarly, respiratory causes, again, a chest X-ray is very helpful in finding out the cause of X-ray, like pneumothorax. Sometimes pulmonary embolism and this other thing, but usually you have got a predisposing factor like patient is being immobilized. Musculoskeletal pain, very common in chest, and a lot of these pains can be troublesome and patients think that this is a cardiac pain. Then again, miscellaneous causes like abdominal issues can also cause chest pain, particularly pancreatitis, cholecystitis, and hepatic ulcers. Hemoptysis, frank blood, spurious, secondary to upper respiratory. It is when, I mean, you can have, sometimes you can have spurious, or usually when we call hemoptysis, it is something which is coming from below the larynx. But anything above the belly is usually called as spurious, or it's not being taken as proper hemoptysis. It is should be below the larynx. So it is called spurious, secondary to upper respiratory tract. And then the pseudo hemoptysis, where the pigmentation in your sputum, that is also called hemoptysis. Depending upon the amount of blood you have expectorated, it can be mild, moderate, severe. Massive is more than 600 ml. But again, there is another way of describing if a patient becomes hemodynamically unstable, even if he has coughed 100 ml of blood, that means it should be taken as severe or massive. So quantity is not only, hemodynamic stability of the patient is also important. Then it's always helpful to differentiate between cough and hematemesis, because our patient always are not sure whether they have, even if they have coughed the blood out, they will call they have vomited the blood. Anything coming from the mouth, for them it is the same, vomiting. So it is very important. Like hemoptysis, there will be cough preceding the hemoptysis. So you have to ask always how the blood came in. Was it during the act of coughing or during the act of vomiting? So that is important. Then frothy, where there will be frothy sputum, it will be hemoptysis. When it is mixed with food particle, it is hemoptysis. You can check the blood pH. If it is alkaline, it is hemoptysis. If it is acid, because it has got mixed with the acid in the stomach, so it will be acidic. And that's why, because of the acidic contents, it becomes dark brown. So usually hematemesis is dark brown, while hemoptysis is bright red. Presence of other previous history of respiratory tract diseases like TB. If you have TB, post-TB bronchiectasis, you are likely to have recurrent hemoptysis. If you have a chronic hepatic disease, liver disease, or you have got chronic ulcers, then most likely hematemesis. So you should always be asking, because you see, for hemoptysis, you have to do a bronchoscopy. For hematemesis, you have to do endoscopy. And these are expensive tests. Unnecessarily, you will do a wrong investigation. These are invasive tests. So unnecessarily, you do first that as a doctor, it is your duty to differentiate what is the cause of that. Now, the cause of hemoptysis could be in the lung, in the heart, or it could be outside the heart. So there are a lot of causes of these hemoptysis, even bleeding disorders, trauma, all this cause that. Finally, wheezing and stridor. What is a stridor? Characterized by prolonged inspiration through an obstructive upper airways, which produces a characteristic sound. Remember that stridor will be during inspiration. So it is an inspiratory sound. When a person tries to breathe, there is a loud sound coming in, and there's breathing, and it's usually audible without an stethoscope. The causes are main airway problem like laryngeal or tracheal obstruction, laryngeal diphtheria, or mediastinal growth, which is compressing the main bronchus. Wheezing is prolonged during expiration. It can happen during inspiration also, but the expiratory component should always be there and should be more marked. And it is usually indicative of lower airway bronchi obstruction. Can occur in respiratory diseases like COPD, asthma, cardiac diseases like left ventricular failure, and sometimes renal failure also. So these are the differences between the stridor and the wheezing, and you should be always sure that one is inspiratory, other is expiratory. Past medical history also relevant, particularly, for instance, if somebody has got a TB and he has come from hemoptysis, so you should always look at his previous x-rays. This is the biggest problem which we face, that patient loses their x-rays. So whenever you get a chest x-ray done on any patient, any relative of yours, ask them to keep it so safe. I always say कि मरीज गुम जाए लेकिन x-ray नहीं घूमने चाहिए, because it saves you from a lot of problems and issues later on. Our belief is that we can get a new x-ray done, but no, you have to compare it with previous. If there is a scar in the previous x-rays, let's say 5 years back the x-ray was the same as today, so we don't need to worry too much about the cause of hemoptysis. Family history, again, there is a lot of diseases, particularly the one which we commonly see is asthma, which is an inherited disease, or there is a strong history. Occupation, I've already said, there are many occupations which can cause respiratory problem. So you have to ask and take a proper history of this, how long you have been into that particular occupation. Examination cannot be, taught by a lecture. You have to practice it. Practice as much as you can so that it becomes next to your nature. There is no, shortcut in learning how to examine different systems. It stands true for everything. I remember when I was in third year, when we were learning an examination, we used to practice on each other. And you have to become so fluent in that without thinking what you have to do, you do it without even thinking about this, what I have to do next. Because when we see in the examination, we see very easily we can pick up that this boy or a girl has not practiced how to perform an examination, because they will be doing one step, then they will go back, think about it, then come and rush to another step. Sometimes they do wrong and they say, oh, I was in a lot of under stress, so that's why I did this mistake. Sorry. There is no sorry in the exam. Remember that if you have practiced, you will never make a mistake. I tell you example, I always go to my doctors or my trainees, postgraduate trainees, that look, when you are learning how to drive a car or a bike, you look at everything other than the road. But once you have learned, you will be looking for the gear, where is the gear, where is the brake, where is the clutch, where is the accelerator, but you will not concentrate on the road. But once you have learned, even if you are singing, you're talking, you're not even thinking, it is done reflexly. So this is what we want, that the examination should be done reflexly. that after percussion you have to go on to auscultation. Before percussion you have to do like the palpation. So all this you don't have to think what you are doing, because when we realize that this doctor or a trainee is thinking what is the next step he's going to do, then he cannot concentrate or pick up the physical sign. So my advice to you is that you should always practice as much as you can, that you perform examination without thinking. And quite often we may interrupt you while you are doing an examination in the exam, and then we will say, come on, then start again. And you totally forgot what to do. But look at the example of, again, driving a car. You can stop it anywhere, and then you can start without even thinking what you are doing. So this should be the state of practice. Now, coming back to the respiratory examination, as you all know that the lungs are made of trachea, bronchi, and these are called conducting. They do not take part in the gas exchange till the terminal bronchioles. The gas exchange starts from the respiratory bronchioles, alveolar duct, alveolar sac, and alveoli. This is the part which is involved in gas exchange. Then lungs is divided into lobes, and lobes are divided into segments. So this is the right lung, 3 lobes, left lung, 2 lobes. Right upper lobe consists of 3 segments, middle 2 segments, and this is considered the lower lobe 5 segments. So you should learn all these segments. Now, whenever we instruct to do the examination, there are different ways the instruction is given to the candidate. For instance, sometimes we will say that examine the respiratory system. When we say the respiratory system, then your then you have examination should start from general physical examination, not directly onto the chest. But if somebody gives you an instruction, examine the chest of this patient, then you directly go on to examine the chest. And if you have time left, you can ask the examiner. Don't go start checking the pulse first, because instruction is to examine the chest. So pulse, you should not be starting with that. But if you have got time left and you want to see that the patient has got clubbing or not, so you can ask the permission that I would like to extend my examination since I have got some time left. So I would like to extend my examination. Then you can do that. But the first instruction which has been given, that has to be followed. So again, I say to you, if you are asked to do a respiratory examination, then you have to do the general physical examination, which is shown in this. All these things have to be checked, and then you go on to the chest. So starting with eyes, you have to check for anemia, there is jaundice, there is meiosis, that is Horner syndrome, or loss of sweating, which is called anhidrosis, which is indication of and it has got a very significant relationship with the CA lung, particularly on the right side, because there is a stellate ganglion that can involve. Then pursing of the lips, typical of emphysema, cyanosis, it can be a central, peripheral, anemia, and then, for instance, cervical lymphadenopathy. Trachea is a part of chest examination. JVP you should be checking, radial pulse, blood, and again in the hands, there are very important findings in the hand. For instance, you can have a flapping tremors if there is a carbon dioxide retention, hypercapnia, you can have clubbing, you can have a staining, like particularly nicotine stain that you have to mention. Peripheral cyanosis, patient may look emaciated, suggesting TB or lung cancer. Similarly, if the patient is very breathless, he may be using accessory muscle, deformity of the chest, all sorts of things that you have to check it while doing the respiratory general physical examination. Then you have to check the vitals of this person, again, depending upon how much time do you have. And then, as I mentioned to you, in the hands, there are some very important physical signs like cyanosis, like clubbing, like Dupuytren contractures. Wasting can be easily seen by seeing the wasting of the palmar and the thinner and hypothinner prominence. Similarly, in the mouth, you have to look for any central cyanosis, any tongue deviation. I mean, there are so many signs which you have to look. Then lymph nodes and thyroid. Thyroid has to be examined from front, and lymph node should always be examined from the back. So lymph node should be examined from the back, or the cervical lymph node I'm talking about. Axillary lymph node is done from the front. So if there is kyphosis, there is scoliosis, all this has to be done. Trachea examination is basically a part of respiratory examination, and during the palpation you have to do that. So these are some of the signs which you have to look for in the general physical examination, which I have already narrated to you. Now, examination of the chest has four components. Start with palpation. And palpation, the first thing you will look for, first of all, you should be, before even you start any examination, you should look at the patient scanning. So now the first thing is that you have to inspect. Before even palpation, you have to do the inspection of the chest. And the inspection of the chest is done from the two ends. One at the foot end. Sometimes the examiners are nasty, like myself. They will be standing on the foot end, and they will. You have to ask them that kindly allow me to stand on the foot end to see the chest. Once you are on the foot end, you bend down, bring your eyes to the level of the chest, and ask the patient to take one or two deep breaths so that you can observe whether the two sides of the chest are moving equally or not, because this can only be inspected from the foot end. The two sides are moving equally or not. So it will give you a very good idea where is the abnormality line. And then you come near the chest, bend down again, bring your eyes to the level of the chest to see whether there is any abnormal pulsation, any deformity that you have to inspect from closely. Once you have done this inspection, then you come on to the palpation. Palpation is done, the first thing you have to look for trachea. Cervical lymphadenopathy, as I mentioned to you, it's always better to do it from the back. If you are examining the posterior or side of the chest, you should be examining from there. Apex beat should be palpated. Now remember that apex beat, once you have palpated and it is palpable, then you have to see which space it is. You have to count the spaces from the second intercostal space and whether it is within the mid-clavicular line or outside the mid-clavicular line. Sometimes the apex beat is not palpable and you have to turn the patient to the left side to bring it close to the chest wall. Remember that when you have done this maneuver, that is, you have shifted the apex beat. So the location of the apex beat is not now the normal location. Now counting if you have palpated it in the lateral position, it is no point in you counting the spaces, because that is not the position. It is, you have displaced the apex beat to palpate it. You can check the character of the apex beat, but you should not localize it. Number one, remember that. And secondly, usually people, what you do is that once they look, particularly in the cardiovascular examination, I have seen that once they have turned the patient to the left side, they palpate the apex beat, and they bring the patient back to his normal position and then put the stethoscope where they have palpated. The apex beat has gone back to its normal position behind the rib. So you have to auscultate in the lateral position while the patient is still in the lateral position where you have palpated the apex beat. So 2 points to remember: once you have displaced the apex beat, then no point in checking for it. And secondly, you have to auscultate in the lateral position because you have brought it close to the chest wall. Expansion of the chest, usually done at 3 points on the upper part, because it's a buccal handle movement. So you should be placing the hand like this gentleman is doing, and you see the movement of your thumb is going up or down. And then at the level of the nipple, and then one at the lower end of the chest, you see, ask the patient to take a deep breath in to see whether the two thumbs are moving equally. The two thumbs are moving equally or not. So this, and then the top part, you have to keep your legs as you see which thumb is moving. So this is the way it has been done on the upper part. So then comes the percussion. Percussion is done first supraclavicular, and then you can do a direct percussion, which is usually painful, directly on the clavicles, direct percussion, and then you have to go on intercostal spaces one by one, and you have to always compare. You can't do one and you can do that. So first thing is that you should be percussing the intercostal spaces in sequential manner: left, right, left, right, left, right. So this is the way it has to be done. It is always preferable that if you are doing a percussion, first you should be finding the upper border of the liver where it is, because then it becomes dull there. Um, Percussion note are being described as dull, stony dull. Stony dull, what do you mean by that, stony dull? Uh, because nobody percuss on the stone. The stony dullness means that when you hit the pleximeter and plexor muscle, the plexor when hits the pleximeter, you feel pain on this finger. The pain suggests that it is a stony dull. So this is a typical of a pleural effusion. If you commit yourself that the chest is a stony dull, that means there is an underlying pleural effusion. Then it is a normal resonant and impaired, that is part of like dullness. So this is the way the percussion note will be. The other thing which you do is tactile vocal fremitus. It is now absolute. We replaced it with the vocal resonance, which is done with the help of the stethoscope. So if you don't do tactile vocal fremitus, as far as I'm concerned, you are perfectly all right, because there is no condition in which vocal fremitus, tactile vocal fremitus will behave differently. So wherever the vocal fremitus is low or diminished, the tactile vocal fremitus will be also diminished. So there's no point in doing that. Now, auscultation, you can first check the vocal resonance by asking the patient to say 3-3 or 99, 99, 99. So you can hear which sort of the vocal resonance is it. Is it vocal resonance has got different, different words being used, like agophony, when the vocal resonance is high. As somebody is agophony is like somebody has got a nasal twang, speaking through his nose. Similarly, agophony is from the nose, and there is whispering pectoraloquy, that is somebody is whispering in your ear. These are some of the suggestions, some of the way we describe vocal resonance. Then breath sounds should be auscultated on each side, left and right, left and right. First quiet breathing, then you can ask the person to take a deep breath in and out. You can hear the added sound, which can be wheezing, crepitations, which is also called as crackles. So always remember that you should be auscultating these from the back. So I think this is all what as far as the chest and the respiratory examination is concerned. I will once again stress that there is no replacement of regular practice of doing clinical examination. You cannot learn by listening. You have to perform it. It is a sort of a skill which you only develop. You cannot learn driving car by learning the theory about it. Unless you sit on the driving seat, you will never be able to learn car driving. Similarly, you will never be able to do the clinical examination properly unless you do it not 1 time, 10 times, 100 times. And don't leave it till you come into the final year or before the exam, because then you cannot be perfect. You start from the 3rd year and carry on throughout your every day. You have to do this examination so that it becomes next to your nature. I always tell my student when they come and the exam, they are nervous. Oh, sir, I'm sorry. I forgot about the percussion, sir. Don't mind that. I said, look, you were tense in the morning also. Did you started eating from your left hand, by your left hand? No, you didn't. Why? Because it was next to your nature. You were not even thinking whether you were using your right hand or a left hand. It's done. You have done it for years and years. So it becomes automatic. And same, we want that the examination should be automatic without thinking. I've seen, the boys, pulling up their sleeves. Prepare yourself before you go on to the examination. There's no point in folding the sleeves, putting the stethoscope in your ear and then taking it out. Sorry, sir, I forgot to do the percussion. This is, once you do this, this gives us a very clear indication to an examiner, which is standing on the side, that you are not fluent in doing the examination. And if you are not fluent, even you know your steps, if you are not fluent, we know that you will not be able to pick up the abnormal physical sign. We can excuse you for not picking up the abnormal physical signs, but we will not excuse you by doing examination in jerky manners. So with that, I end the examination. Thank you very much.